Welcome to another episode of Stories from the Edge of Life. We once again have a very special guest, Dr. Charles Von Gunten. Hello, Dr. Von Gunten.
Pleased to be with you again, Dr. Bhardwaj.
Thank you. Dr. Von Gunten, would you mind introducing yourself once again to our audience?
My name is Charles Von Gunten. I'm editor-in-chief of Journal of Palliative Medicine and professor of medicine.
Great. And I'm Parag Bharadwaj. I am a hospice and palliative medicine physician in the US and trained under Dr. Von Gunten. Dr. Von Gunten, you shared a glimpse of your professional journey. This interview, I would like to hear from you about how patients influence you as a person and your experiences with patients. We heard about your experience with your first patient on hospice, which basically determined your trajectory as a clinician and also as a national and international leader in the field. What were some of the other striking experiences that you had with patients?
The patients I've taken care of are the ones that are most responsible for everything in my professional career. Sir William Osler, who really defined the path of medicine, not just in the US, but around the world, said it's the patients that teach you the medicine. And therefore, when you train, you should be at a place that takes care of lots of patients because they're the ones. The patient that first pops in my mind was when I was training as in medical oncology. And he was a young man, 37, with small intestine cancer, a very rare cancer. Still difficult to treat. At that time, chemotherapy played no major role. And this was early in my days before I knew that much about palliative medicine. And yes, we'd treated him with chemotherapy. It hadn't worked. He was at home, and I made home visits to see him at home. And his nausea was not very well controlled. And yet I kept seeing him, and I remember it vividly. I remember the smells. I remember him lying on his sofa. There was an IV going. He had bowel obstruction, not as a single site, but as multiple obstructions. And his nausea and his pain was controlled okay, but not fabulous. I went, because I'd read, gee, you should go to your patient's funeral. So I went to the wake. I couldn't go during the day, but it was in the evening. And there was a murmur in the room. There were probably 200, 300 people there. And family came around when I had visited him in the day, he was the only one there. Family were working. But they came up, are you the doctor? Are you his doctor? Oh, and then there was the through, and then they took me up to see the body. And I thought, but I failed. I didn't make his cancer better. I didn't even do all that great a job of controlling his pain or his nausea and vomiting. But I kept showing up because that's what I could do. I could be there. And they perceived that I had been the best doctor. I had taken care of him. I had helped him, but although I hadn't fixed him, I had been his doctor. That core, what is it to be a doctor to someone? Was it to be a physician? It's not just a technical achievement. Yes, it's fun to do things right, but when things are difficult and you keep showing up, that has been formative in my career. When things are difficult, the most important thing to do is to show up, be there in the presence, be in the midst of the difficulty and persevere. And that he's still sort of there telling me, that's the way to be as a doctor. There are other patients that pop to mind. The um, the work that Kathy Foley and Russ Portnoy did at Memorial Sloan Kettering that then moved cancer pain management around the world. I learned from them and adopted that, and lo and behold, yes, pain could be controlled even at high doses of opioids and with choanalgesics. The whole WHO ladder thing worked. But I remember a patient, what about all the other patients? And it was in my early career, I'd started this palliative care consult service. I was seeing patients all over the hospital, but initially it was mostly oncology, whether on the oncology unit, in the general medical floors, in the ICU, sometimes in the emergency department. But I got a call from orthopedics. Would I please see a patient on the orthopedic ward, chronic non-union fracture. She was in for her third revision and she wasn't on the pathway. They'd done her standard approaches. She was still complaining of pain, not participating in therapy. And it happened to be the chairman of orthopedics patient. And said, sure, I'd show up and see her. She was a psychologist, very articulate, described her pain. It was clear, nursing staff, she was pretty much labeled as this dirtball, drug-seeking, uncompliant patient. And I saw a really smart woman, difficult pain syndrome, wanting to get better, but stymied. And I said, well, we could try a cancer pain approach. But they of course had stopped her patient-controlled analgesia. She was no longer getting opioids. And I said, I think we need to put her back on a morphine drip with patient-controlled analgesia. Her doses needed to go from here to here. And attending, when I called him and said, this is what I think we should do, was livid. And in listening to him, I remember having the phone, needing to take it away from my ear because he was so loud. And what I heard behind that was, I'm frightened. This makes me uncomfortable. And so I said, gee, if you're uncomfortable, I'm happy to write the orders for this. I'm happy to take responsibility for writing the orders. And he was very peremptory. He said, fine, you do it. It's on your head. You do it. And he hung up. So I did. And I talked to the nurses. Well, the patient immediately sprang out of bed, started going to therapy, was discharged in 2 days. She was still on high doses of morphine. I converted her to oral morphine in the standard cancer pain way. And since there was no outpatient clinic, I had her see me in my outpatient oncology office, and the office manager was fine, didn't bother anybody there. And over a couple of months, I tapered her off and she had a full recovery. She had her bone then, she had union finally, it healed. We tapered her off and she went home. The idea that good pain management, including some of these techniques that were developed only for cancer, they have a broader application in medicine. Just because we make these distinctions for ourselves doesn't mean that is necessarily true for the rest of the world. I get annoyed when people say, well, I only do cancer, or palliative care is only for cancer, when these approaches, this trial and error, they work for others. She's core to my memory of, you have to give patients a chance. And the other thing I discovered in that, because I was in a large oncology group there at Northwestern, and we just started, there was this need for outpatient follow-up from people we'd seen in the hospital, particularly for pain management, sometimes for other. Their physicians just didn't know and were uncomfortable managing that in their offices. And I could see patients, I could bill, the office didn't mind. And what I learned through this course, probably a third, a quarter of my outpatient practice ended up being these outpatient palliative care follow-ups. Patients that didn't have cancer, but they were coming to a cancer office for follow-up, didn't bother them. They didn't know, they knew they didn't have cancer, but being in a waiting room with cancer patients waiting for treatment or whatever, totally changed their view of themselves. The sort of the pity party, oh, I have this terrible chronic pain, and oh, I didn't need to say anything. They did their own therapy. They looked around the waiting room like, whoa, not so bad. I look pretty good compared to the rest of these people here. It made a very easy outpatient. The main challenge then was, all right, how do you keep up with the volume? Because the scope of that is so, it's so large, but that is what has led to large demand for outpatient palliative care, because that's where most of the suffering is, and being able to see patients in that setting. So you just, I have the firm conviction, it doesn't matter where you start in this field, whether you start in dedicated inpatient units or consult or outpatient follow-up, you end up, a comprehensive program has to be in all those places because that's where the patients are, and they naturally lead somewhere else. And if you're going to provide a good care, you got to figure out how to provide it in all those places. And so every program ends up taking on the same shape no matter where it is in the world, because of that.
Right. So it's interesting because patients definitely influence how we make choices, not only in a professional but also in a personal lives.
Mm-hmm.
Any anything you want to shed, any light you want to shed upon how your interaction with patients changed you as a person, or perhaps some of the life lessons that you picked from them as to what's important in life, what is really meaningful in life, what should be our priorities, and so forth?
The biggest thing I think of when I think, what have my patients taught me? The number one issue is courage. People with serious illness, my biggest exposure has been to patients with cancer, but also with other serious illnesses. The courage to face it and to keep being themselves is the striking. I don't think of myself as a particularly courageous person. I get distressed by whatever barriers seem to get put in the way. And yet patients who have far more overwhelming issues, whether it's metastatic cancer, or in some ways, one of the things I've learned through my career is there are worse things than cancer. Even metastatic cancer, you know what it is, it has a defined course, it has an end. There are some diseases that go on for a lifetime, 40, 50 years. The courage to face that with equanimity, with good humor, that anything that I think bothers me is so small in comparison to what others, and if they can do it, well, I should try and measure up as well. And I don't have as much to worry. It's just that my issues just aren't as big a deal as what some other people are facing, and that has led me to have courage myself. What you and others observe that I've taken risks in life related to the specialty or related to building programs in new institutions. Well, if patients can face serious illness and all that means for who they are, their families, their well, then I can do it. And actually it's not that big a deal. So it allows me to see the whatever hurdles are, they're actually smaller than I think they are, and it's easier. Why not? What's the worst that could happen? And the worst is never anything as bad as what I've seen patients face.
Right. Now, you mentioned, examples of patients. Do you do you do you have any patients that come to mind when you think of patients that have had to struggle for years and decades with chronic conditions that you had to take care of, and what you learned from those experiences?
I'm thinking of a man with sort of a difficult autoimmune disease. I mean, yes, he had arthritis. Yes, he had bowel issues. It was hard to, but he had difficult abdominal pain, um, pain, pain in his hands and his knees, and I mean, as you know, crampy abdominal pain is one of the most challenging pains because it's not particularly responsive to the opioids. And arthritis pain, joints, again, not so responsive. So I remember we first went down the opioids path, and of course it didn't do anything. Um, and needing to prescribe, all right, well, what does crampy abdominal pain mean? The discoordinated contraction of the bowel leads to stretch, and stretch pain, that's different receptors. So going down the antispasmodic pathway and then the NSAID pathway for hands, needing to combine medications in complicated patterns. But for this particular man to be able, what he wanted to work. He wanted to be able to take care of his children. He wanted to be able to not, it's been called, being nailed to your body. He wanted to get away from his body to appreciate the rest of his life by is conceiving of what are the molecular pathways, what are the mechanisms, combining the drugs, using the patient's report of are things better or worse on balance, including the side effect profile, coming up with, in the end, a 4 or 5 drug regimen. But, like a house of cards, when it was all together and he walked into the office saying, I'm able to function. I'm able to go to my kid's game. I'm able to, I could have sex with my wife. I could have sex and I enjoyed it. I wasn't just doubled over. I was able to go to the sense of achievement because it felt like I took the best of me as a biochemist, as a physician, as a human being, listening to suffering, and trying to put it together in a way that others had not been able to do, that led to function over years and years. Because autoimmune diseases don't kill you often. They're just a chronic, difficult problem that emerge in midlife but go on for 20, 30 years. To make a difference in his life, that for me, with my background, it was like the perfect, all these 3 pieces, the human, the biological, the scientific, you can put it all together to help somebody. It's so meaningful, and that has been fun. And my career was often as I used to, well, and even as a way to limit patients, I thought of myself as doctor of last resort. Right, the patients ended up getting sent to me and again through my networks of the physicians. They needed to have seen anesthesia pain. They needed to have seen other people. If that could be managed, it fine. But Everything else had failed. And they came to me, a medical oncologist who was doing palliative medicine. And therefore, I had the freedom to use opioids in non-cancer diagnoses. Being able to put together unusual combinations of medications with, and the key measure is function, because some people never got rid of their pain. Most didn't. But if it could be managed enough, the nausea managed enough, the dizziness managed enough to function, I think that was such a reward. And I think, there's so many patients where it doesn't take 100% change in symptoms. A 20% change is the difference between wishing for death and I can get up and function today. And that was a mark I could.
That's amazing. And I think often, for the sake of our audience, what we take for granted is often that, a lot of patients of ours that we take care of would love to achieve, right? As a baseline. So yes, so Dr. Von Gunten, throughout your career, you have come across and you've witnessed a lot of suffering in patients. How did you take care of yourself?
That's a pointed question. I have to first, well, I think patients help. I mean, you can see yourself in a mirror in some ways. Yes, I tend to overwork. I have I found great meaning in my work, and because I'm not married and have no children, I am free to spend myself in my work. So and yet although for some patients, their work was meaningful to them, it wasn't the only meaning. So for me, being able to give myself permission to enjoy things out, either to say, well, I find great meaning in my work, and I'm not going, the life balance folks who say, well, you must do this and must do this, gave me permission not to listen to that. But when I needed and wanted to do, whether it's go on holiday or fix up my house or buy new clothes that gives me pleasure, when you see patients, because it's always unique, what gives that person deep pleasure and deep satisfaction is very unique to them. And then the permission for myself, all right, I get to do that for myself too. The things that are meaningful, that may not be meaningful to anyone else. Well, they can't know. And so I try not to listen, or I don't give much credence to, well, you ought to do this or that. But the permission to listen to what I most want, and that would be fun, even if it's frivolous. Well, so what? It gives me pleasure, it gives me balance, it gives me a sense of joy that allows me to go back to the work. That's what my patients have given me.
Sorry, I was saying we are all unique and we have our own outlets in terms of what we value and what we enjoy.
And
So
there's
as we
nothing wrong with being distinctive or an outlier. Regression to the mean is more than just a mathematical, statistical thing. You see it in human behavior, as opposed to, yes, I'm an outlier, and enjoy. Fine, just because others that's average doesn't mean I have to be average or in the 2 standard deviations from the mean. I can do things that give me pleasure and enjoy it, and I don't have to be judged by others in the way that my patients don't want to be judged by other averages because it was meaningful to them. I'm remembering a patient who was so influential to me. Middle-aged guy, thought he had a cold and came to the hospital. And it turned out he had an obstructive pneumonia of advanced cancer. And I was asked to see him as both a medical oncologist and as a palliative medicine doc with his pain. For him, the thing he most wanted was not be in the hospital. He didn't really care that much about living a long time, but for him, he had always gone to rural Vermont every summer to live out of doors in a tent, doing elaborate puppet theater with a group that he'd been with for most of his life. They were focused on world hunger relief, and it was kind of a hippie thing all in this field. And as his medical oncologist, I was thinking, oh my God, you have multiple bone fractures, you could, or multiple bone mets, you could have fractures, you have bad bone pain, bad movement pain, and you want to be in a field in Vermont, 100 miles from the nearest hospital. And at that time, I was practicing in Chicago. That scared me to death. And I wanted to say, no, you can't go. But this, all right, whose issue is that? His or mine? Well, it was mine. I was the one that was anxious. He wasn't anxious. I was anxious. I was going to have him change what he was doing to make me feel better. Well, how perverse is that? He had an emergency medical technician daughter. She was going to go. She was happy to and I made sure she had the drugs. I made sure they knew what they were going to do. But they wanted to try. They were willing. That was, he taught me about, I need to approach all patients with, you see this, we end up being, or I'll just use the I word, I can substitute my needs for patient needs if I'm not careful. I can express my anxieties, but in the end, it's not about me, it's about them. So that willingness to let people be themselves, including to do things that are out of the ordinary or risky, as long as they understand and you try and prevent it, but you can't change the future. I need reminding of that frequently, but the willingness to trust patients to know themselves and give them the tools to live their lives, that's a lot more fun than feeling like I'm responsible for everything that happens to them in their lives. That patient, and then the gratitude, that same patient, towards the end of his life, he was enrolled in a home hospice program. I had seen him at home, and I thought he was in the last week of life. He had begun to lose consciousness. And he had bad bone pain. And we had controlled it through most of his course with oral corticosteroids. But of course, he stopped eating and drinking. And he became restless and agitated. And of course, I had read at the time about the rectal administration of more than just opioids, of corticosteroids. So I told his wife, well, just put his dexamethasone, just poke it up his bum. And I remember sitting at my desk at 7:30 in the morning, and I got a telephone call from the patient. He was awake. I want to go to Pennsylvania. A man who I thought was days of dying had now perked up because of his dexamethasone. But for how long? Who knew? I want to go to Pennsylvania. He was in Chicago. This is not a wealthy family, could not do a private jet to Pennsylvania. So in good palliative care fashion, I said, well, why? Well, his son was getting married at their home outdoor ceremony, and they had just had his first grandchild. who had been born a week, and he wanted to see his son get married, and he wanted to see this first grandchild before he died. Well, that sounds wonderful, but then the practicalities. So of course, it wasn't just his decision. He was totally bedbound. So I said, well, what did your wife and your daughter think about? Well, they were all for it. And so they got on the phone. Well, they're all for it. Well, then what does it take to move a dying patient? Yes, he'd had the steroid-induced resurrection, but well, it took a team, and it was in the U.S. the hospice program. It's nurses, social workers. So talk to them. Social work found out. All right, well, it's true in the U.S. Well, around the world, the FAA says if a patient dies on the plane must land. Well, just because this guy had a goal doesn't mean he should discombobulate everybody else on that plane if he should die, because I was quite clear he could die in transit. Was it my limits to tell? And so it was the social worker that got it all organized with the oxygen and whatnot. And when we met with them and said, well, if he should die, you don't need to bring it up. If he just tuck up his blanket, and if anybody asks, tell them he's sleeping. Well, it turned out he didn't die during that he made it, and he made it to the wedding. Now, not everyone wants a dying patient at their wedding, but this son and his new wife did want him there. He was at the wedding. He got to see his grandchild, and he died the day after the wedding. What that case taught me is it's not about my goals. It's about their goals, enabling them to achieve their goals, including when there's a risk. They might not make it, but they understood. And that gave me enormous pleasure, not just for them, but for all the patients that will come after, to trust people and let them make the ultimate choice. It's an informed choice. It wouldn't be my choice, but it's not my life.
Absolutely. So thank you for sharing that, Dr. Von Gunten. I think the bottom line that I'm hearing from you is that we all need to make the most of our lives and appreciate it. And how lucky are we to be in this profession, to be constantly reminded of this by our own patients. And I look at it as the generosity that they're able to share their insights and wisdom with us.
Those are certainly the things that I have taken away from my patients throughout my entire career.
Thank you very much, Dr. Von Gunten, for sharing your insights. And I'll hope to have you again soon.
Thank you.